This video is on atrial fibrillation, anticoagulants, and rate control. What's going to be covered is an overview of atrial fibrillation, really with a primary focus on the chronic outpatient management, but definitely we'll touch on the inpatient side as well. We're going to outline the priorities that you have. We're going to help you understand the decision-making process for anticoagulating when, why, and what. There will be a review of the anticoagulant drugs and the rate control drugs. Some facts and information. It's the most common cardiac arrhythmia, and it is characterized by that classic irregularly irregular rate without a regular RR interval seen on an ECG. There's also not a clearly defined P wave. In other words, the nicely coordinated P before QRS of the normal sinus is no longer there. There's a disorganization, there's a loss of electrical and mechanical coordination between the atria and the ventricles. And the other interesting things are it's more prevalent in men, and the prevalence increases with increasing age. It is most commonly caused by hypertensive heart disease, coronary heart disease, heart failure, cardiomyopathy are associated with it. The pathophysiology involves changes in the electrophysiology of the atrial myocardial cells, which we covered pretty thoroughly in the video on the arrhythmia, cardiac antiarrhythmic drugs. There's not a definite prevention strategy, although globally you might say that preventing heart disease, in other words, not smoking, exercising, controlling your weight and your stress, all those things may help prevent it, but really studies have not shown definitely a way to prevent it. It typically presents acutely with shortness of breath or feelings of palpitation, and the diagnosis is made by EKG. These are the four most common classifications of atrial fibrillation. I, rather than reading this to you, will just let you pause this and read over the four different most common kinds. But let me just suffice it to say that anticoagulation is going to be primarily considered for the lower three categories, as well as rate control, depending on symptoms. Okay, so this slide is pretty important for you. The three keys to atrial fibrillation management. First and foremost, stroke or TIA prevention. As you know, because of the incomplete emptying of the atria and the impaired ventricular filling just inherent to AFib itself, people are at risk for stroke. And oftentimes, the first presentation of atrial fib is with embolic stroke. Be that as it may, let's hope your patient is lucky enough to be discovered before that happens. So you have to prevent the stroke for obvious reasons. The next decision-making point is their heart structure. Do they have a prosthetic or do they have a native valve? People with non-valvular atrial fibrillation have 5 times the risk of stroke compared to those who are in a normal sinus. So this is really why it's such an important conversation and topic. NVAF, which is the abbreviation for non-valvular atrial fib, is defined by the American College of Cardiology as having no prosthetic valve, no mitral valve surgical repaired, no rheumatic mitral valve stenosis. Why is that important? You will see, because the choice of anticoagulant is based on, is it NVAF or do they have a prosthetic valve? Next, you're going to look at rate versus rhythm control strategy. Restoring sinus rhythm, which is number 3, is an electrical conversion, the cardioversion, beyond the scope of this presentation. But controlling ventricular rate is dependent upon the ventricular rate itself. There isn't a definite optimal ventricular rate, but usually less than 80 is the target. And this is kind of what determines whether it's urgent, whether a person needs to be transferred to the hospital for IV pharmacoconversion, or whether they can be managed outpatient. This slide gives you a few more points to consider in terms of where the patient can most safely be managed. If this is acute AFib, if there are urgent symptoms, if they are unstable, if there's a very, very rapid ventricular rate, they would need to be taken to the emergency room and pharmacotherapy or electrical therapy be done there, whether it's IV antiarrhythmic drugs versus cardioversion. And the management decisions are definitely based on age, symptoms, and embolic risk. One of the things I wanted to say too is that in my last slide about the risk for stroke with NVAF, that risk is for people who are not anticoagulated, just so you know. The other thing you're going to think about moving on is if it's new onset versus chronic. I've had plenty of people that I've diagnosed in the office who have been stable, who we've started on anticoagulants when appropriate, and metoprolol or other rate controlling drug, and then you just follow them up, you order your echo, and so forth. You also want to consider their risk for heart failure. Do they have underlying structural cardiovascular disease or heart disease? And so is this uncontrolled rate potentially going to exhaust their heart? More on stroke prevention. Every single patient who has new onset AFib must have their risk for stroke or thromboembolic events determined. The way this is most commonly recommended to do is with the CHAD2 VASC tool. It looks at elements such as age, gender, comorbidity. Patients who have a score of 2 or greater have a moderate to high risk of thromboembolic event or stroke. So those people you move into a discussion with on anticoagulant and you make the decision in a shared manner. I've given you the link to the calculator that is used in the next couple of slides. You see the various elements that contribute to the scoring. You see how age is really quite a big contributor, since 2 or more is a definite recommendation towards anticoagulation. There are even some sources that recommend a serious discussion and consideration with a score of 1. This is a screenshot of the scoring tool, the online scoring tool. You just kind of click the yeses or the nos. This patient has a score of 4, and so they would require an anticoagulant discussion. They are between 65 and 74 for 1 point, female for 1 point. CHF history, no. Do have a history of hypertension and a history of diabetes. You can go online and play with the scoring. It's very interesting. More on stroke prevention. As we established, we know the score is 2 or greater. The important part of the conversation you can have with your patient is that by being on an anticoagulant, their risk for stroke goes down by 2/3. So in other words, if you don't go on anticoagulation, you are 2/3 more likely, or 66%, more likely to have a stroke than if you do go on anticoagulation. Our choices are warfarins, the NOACs, or the DOACs. You may have seen those terms floating around. NOAC and DOAC are referring to the same thing. NOAC is the non-vitamin K oral anticoagulant, DOAC, the direct oral anticoagulant. Remember, the key question for your decision is, do they have a structural heart disease, such as a valve replacement or a rheumatic mitral valve? If they have that, they must be on warfarin. They are not a candidate for the DOACs. Why? There is not enough robust data showing that the NOACs or DOACs have the positive prevention of stroke that warfarin does. The data will probably be coming, but we just don't have it yet. The other thing to do is, if you're not sure if they may not have a prosthetic valve, but maybe they don't know if they've had any mitral valve problems, then they need an echo. You could certainly safely start them on a DOAC and get the echo And if you find they've got structural problems, then switch them to warfarin. It's kind of better, the DOACs and the NOACs, when they are indicated and when they meet the guidelines, that's the preferred recommended choice rather than warfarin. Showing our targets for anticoagulant drugs. The use of heparin and low molecular weight heparin is not really going to be covered in this lecture, but we're looking at the vitamin K agonist, which is warfarin, the direct thrombin inhibitors, and the factor Xa inhibitors. So those last two groups are both known as NOAC or DOAC. You'll see them both. They can be used interchangeably, and it just shows the targets for each drug class. Using the image from our text on page 865, you can see the three places at the clotting cascade where warfarin acts: factor 11, factor 7, and factor 10. This is why warfarin has such a variable onset, because it has to stop the production of so many different factors, whereas the exabans, the direct factor Xa inhibitors, your rivaroxaban, your Xarelto, they take out one place, factor Xa, further down the cascade, whereas Pradaxa is a direct thrombin inhibitor. Listing for you the different classes. So you've got your direct factor Xa, you've got your direct thrombin, you've got your vitamin K antagonists. Speaking more about direct factor Xa, they are very cleverly named generically because the name tells you the mechanism of action with the XA, so they inhibit factor Xa. These are apixaban, rivaroxaban, and edoxaban. The double asterisk by edoxaban is that there's not a definite reversant agent for that one yet, whereas all the others do have one. Pradaxa, the dabigatran, that's the only one in the class for direct thrombin inhibitors, and then of course warfarin. All of these have FDA indication for non-valvular AFib. The antidote is listed. Pradaxa has Praxbind, and of course warfarin has vitamin K. And warfarin is also indicated for the NVAF plus any AFib with valvular disorders. Even though in non-valvular atrial fibrillation, either the DOACs/NOACs are preferred first line, but there are times when you're going to go with warfarin, even if they could take a NOAC or DOAC. Here is when you would do that. Perhaps you've got a patient who is already on warfarin for something else, and they don't want to change. They don't mind the testing. They've been stable. That would be someone you would just leave on the warfarin. If they have a mechanical heart valve or mitral valve, of course, and the GFR is a key thing to look at because the lower GFRs tend to not be in agreement. They're not okay with the NOACs, DOACs, other than apixaban. It is approved. That's the only one that's approved with a GFR less than 30. These can be cost prohibitive, and your patient's on Medicare. Sometimes it's a lower tier, making it very costly. I've had people that I've had to switch from a factor Xa to a direct thrombin and vice versa, depending on their formulary. Also, if they're taking phenytoin or a protease inhibitor-based antiretroviral therapy, actually warfarin is preferred. Or if for some reason they're not a candidate for rivaroxaban or edoxaban, the dabigatran and apixaban are BID dosing. And if the patient says, I will not remember to take it twice a day, good on them, they know themselves. So then rivaroxaban or edoxaban are both QD, but if for some reason they're not a candidate, then you would give warfarin. Of course, I had to include this slide on the drug-to-drug interactions that are possible. What I wanted to just point out to you is that the reason the phenytoin protease inhibitor antiretroviral are not recommended if the patient is taking those, it's not recommended to prescribe a NOAC, is because of drug interactions, because those are inducers and they tend to decrease the effectiveness of the NOACs or DOACs, and we're not monitoring labs, so we can't really adjust like we can with warfarin. This slide is showing you on the column on the left things that increase the INR. This is drug interactions with warfarin. So just think about, are we talking about an inhibitor or an inducer? Look at some of the key players. We've got rosuvastatin at the bottom, which is Crestor, simvastatin, and we've got sulfamethoxazole, which is one of the ingredients in Bactrim. Over on the right, things that decrease the INR are not super common things, it's a much shorter list. This slide is addressing the rate control, which is our second consideration in the management of AFib. So, is the patient hemodynamically stable? You always want to check their TSH. You want to rule out any other underlying cause. Sleep apnea, which is OSA, is one of the things that can be an underlying cause. Now, granted, those are going to take a couple of days turnaround to get that done, but in the immediate moment, are they stable? What is their ventricular rate? And again, there's not a definite guideline for target goal, but that's generally where we head, is with a ventricular response of less than 80. So we've got the beta blockers, which, as you may have noticed in the video on antiarrhythmic drugs, they are a class 2 AAD, particularly metoprolol and propranolol, because those have the 24-hour length of effect. Beta blockers have been proved to be more effective at rate control during exercise, which is something that is desirable. For the calcium channel blockers, again, it's the non-dihydropyridines, your verapamil or diltiazem. In the acute care setting, IV diltiazem is the preferred of the non-dihydropyridines. You want to be cautious with both these classes if you have a patient with acute heart failure, because you don't want to suppress their myocardium too much. DIG is also always an option if they're not adequately controlled with a beta blocker or a calcium channel blocker. I just tend to go with metoprolol XL for my rate control, unless, of course, there's a contraindication such as severe, moderate or severe uncontrolled asthma, in which that could suppress or lead into bronchospasm. This atrial fib management algorithm is on page 344, chapter 23. Just kind of study that and it will tell you what you need to know. All right, we are at the end of this presentation. To summarize, atrial fib is the most common arrhythmia. Your top 3 priorities are stroke prevention, rate control, rhythm normalization. Consider if they're stable or not stable. You can manage it yourself in primary care, but if you think they're a candidate for cardioversion, you would refer to cardiology. Always shared decision making, especially when it comes to anticoagulation. They need to understand why they're on it and what they need to be mindful of and careful of. Remember the structure of the heart, the valve, the presence of non-valvular AFib. Which classes of anticoagulants can they take? Think about when can they not take the NOACs and DOACs? Is this acute AFib or is it chronic AFib? Thank you. And next slide will have the references with no narration. I do want to say that if you have access to UpToDate, it is an amazing reference. It is an amazing resource. I actually used my CME money to purchase it because OSF does not provide it anymore, so I highly recommend that. I just wanted to put a plug in. Thank you for your time and watch for the questions.